Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria, and I am currently a PGY 5 resident at the University of Pittsburgh. Today, I'm very excited to dive into a brand new disease site for this channel, which is lung cancer. Lung cancers are extremely common in the United States, representing the second most common type of cancer if you don't count skin cancer. And they are actually the leading cause of cancer death in the United States as well. Very broadly, lung cancer is divided into two different types based on histology, and these are small cell versus non-small cell lung cancers. Small cell lung cancer accounts for only around 15% of lung primaries, and it represents a neuroendocrine cell tumor, a high-grade neuroendocrine tumor. Small cell lung cancers tend to be more aggressive, and they have a much higher propensity for distant failure, especially brain metastases, as compared to non-small cell lung cancers. Small cell lung cancers are also almost always associated with cigarette smoking. Non-small cell lung cancers are frequently associated with cigarette smoking, but up to 20% may not actually be related to smoking. And adenocarcinoma is the most common type of non-small cell histology, and adenocarcinomas are typically the histology that we see in patients that do not have a history of smoking. Other non-small cell histologies include squamous cell carcinoma as well as large cell carcinoma. It's very important for us to identify the histology of lung cancer because that certainly affects our treatment paradigm. The most important distinction to make is between small cell and non-small cell lung cancer because these two diseases are treated as completely different diseases. They have a completely different treatment paradigm. And then within non-small cell lung cancer, the histology is also important because as we will see, it can sometimes affect our treatment decisions, although all non-small cell lung cancers typically fall under the same treatment paradigm. My goal in this overview lecture is to really talk about the presentation and workup of lung cancer very generally, and then briefly review the staging and management of non-small cell versus small cell lung cancer. And then we will spend the remaining talks in this series really digging into the evidence behind our treatment paradigms. Let's start with the basics of presentation and workup. Ideally, lung cancers would present to us on screening CT scans. We know that the risk of lung cancer is very high in our population, and so there are screening guidelines for the USPSTF for patients that have a smoking history. So the guidelines were updated in 2021, and the most updated guidelines recommend an annual low-dose screening CT scan of the lungs for patients ages 50 to 80 years old who have a 20-pack year smoking history and are either active smokers or have quit within the last 15 years. So previously that age group was 55 to 80, I believe, and they required a 30-pack year smoking history. But in 2021, they actually expanded their guidelines to include patients ages 50 to 80 with just a 20-pack year smoking history, and anyone that actively smokes or has quit within the last 15 years. With low-dose screening CTs, we are able to detect lung cancers at an earlier stage, which often spares patients from more aggressive therapies. If cancer is detected at an early stage, then oftentimes patients won't even need any systemic therapy, and they can just be treated with either surgery or radiation. Unfortunately, however, despite having these screening guidelines, I don't think screening in the U.S. is robust, and unfortunately at this time, I think less than 20% of lung cancers are detected on screening CT, and oftentimes they present much more advanced. When lung cancer presents based on patients coming in with certain symptoms, it really depends on how advanced the tumor is. If the tumor is locally advanced, it can cause pulmonary symptoms such as cough, shortness of breath, hoarseness, chest pain. Sometimes patients can have weight loss. They might present with a pleural effusion or a post-obstructive pneumonia. Certain cancers we know can be associated with paraneoplastic syndromes. So squamous cell carcinoma is often associated with hypercalcemia from release of PTH-related peptide. And then there are a few different paraneoplastic syndromes that can present with small cell lung cancer, including SIADH, Lambert-Eaton syndrome, and cerebellar ataxia. If cancer is metastatic at diagnosis, then we can have symptoms from wherever those mets are. So if there's brain mets, it can be headaches or neurologic symptoms. If there's bone mets, it can be bone pain and so on. I will say, I mentioned earlier that small cell lung cancer has a much higher propensity for metastases, especially for brain metastases. And while that is true, non-small cell lung cancer has a very high risk of distant metastasis and brain metastasis as well. I think the difference is around 60% of small cell lung cancers are metastatic at the time of diagnosis, and around 40% of non-small cell lung cancers are. In terms of risk factors for lung cancer, smoking is obviously a huge risk factor. We also ask about family history, medical history, such as having pulmonary fibrosis, and then various exposures. So things like radon, asbestos, and then various occupational exposures are important to inquire about when obtaining patient history. Now, we said that smoking is a huge risk factor for lung cancer, and that when patients are diagnosed with small cell lung cancer, they almost always have a smoking history. This is not necessarily the case for non-small cell lung cancer. Patients with squamous cell lung cancers almost always have a history of smoking, but non-smokers can develop lung adenocarcinomas. And for non-smokers that have lung adenocarcinoma, especially females who are non-smokers, they have a higher likelihood of carrying something called the EGFR mutation. So this is a targetable mutation, and we actually have therapies that specifically target the EGFR mutation. And this disease seems to act a little bit differently compared to other non-small cell lung cancers. Patients with the EGFR mutation tend to have lung cancers that have a higher propensity for brain metastasis, but in general, they also have a higher or an overall better prognosis, I should say, and they respond very well to EGFR treatments. So that's just something to keep in mind, especially for females who are non-smokers. When we see patients like that, we definitely want to think about the potential of having an EGFR mutated lung adenocarcinoma. In terms of how we follow findings that we see on a screening low-dose CT scan, it's really going to depend on what the lesion looks like, how large it measures, and also the patient's risk factors as well, such as their personal history of smoking, other exposures, as well as their family history. So we really take all of these into account in order to make recommendations on what to do with different nodules that we see. So nodules that are less than 6 millimeters, or nodules that are even 6 to 8 millimeters in size, it's often very much a case-by-case decision. We really look for, what those patients' risk factors are. Does the nodule appear malignant? So for example, does it have spiculated margins? And then we do like to get sometimes shorter intervals. So if we're really concerned, we might opt for, instead of a low-dose CT, getting a diagnostic CT maybe at 3 to 6 months if we're really concerned about something. And if it's enlarging in that shorter time interval, then that makes us afraid too that this could be something that's cancer, and it will prompt further workup. Anything that measures 3 centimeters or larger on a CT scan is considered a mass, and it's really treated as a cancer until proven otherwise. And so these, masses will definitely go for biopsy and PET scan and things like that and be worked up as if they are a cancer. It's really these smaller nodules that sometimes represent a gray zone, but that's why it's really important to have kind of robust follow-up for these patients and be closely following anything that might look concerning. And like I said, we really take into account the size of the lesion. If we have kind of serial evidence of growth, then that is definitely concerning. And we take a look at the margins as well. So something with kind of a smooth margin, as shown on the left-hand side, is more likely to be benign. And then when we see spiculated margins, so kind of those sharp spiculated edges, that's definitely more concerning for malignancy. So patients may present to us in a variety of ways. It may be an abnormal finding that was just seen on a screening CT scan. Oftentimes, patients will go to the hospital for other reasons and have a CT scan for something completely different, for example, to rule out a pulmonary embolism, and then they will incidentally be found to have a suspicious nodule or a mass. Or sometimes patients may present with, like I said, symptoms from more locally advanced or even metastatic disease. In terms of workup, we always start with a full history and physical. As I've been mentioning, we need to inquire about different risk factors, obviously their age, their medical history, occupational history, and family history, as well as smoking. And if they are active smokers, we need to engage in smoking cessation counseling. In terms of labs, you always want to start with a CBC and a CMP. And if patients are being considered for surgery, we will obtain pulmonary function tests as well. That's typically obtained by the surgeon if they're evaluating them for medical operability. At minimum, we need to have an FEV1 and a DLCO of at least 40% for medical operability. So the FEV1, remember, is a measure of your forced expiratory volume, and the DLCO is a measure of your diffusion capacity of oxygen at the lung. And so those need to be at least 40% at minimum for medical operability. And we'll take into account not only their PFTs, but also other comorbidities. For example, if patients have significant history of asthma or COPD, that can all kind of play into their risk if they are being considered for surgery. In terms of imaging, we definitely want to get a dedicated diagnostic CT of the chest. We don't need contrast to look at the lung tumor itself, but sometimes administering contrast can help us if we are concerned about lymph node involvement. We should always also get a PET scan for our patients, and that can sort of help us with determining if there are lymph nodes involved. PET scan has a very high sensitivity for the primary lung tumor. The sensitivity is around 96%, which means that it's good at ruling things out. So if the PET scan is negative, then that gives us a high likelihood that the tumor is probably not involved. The specificity is lower, around 79% for the primary tumor. And then PET scan is helpful for nodal staging. So if things light up on the PET scan, we are very concerned, but it definitely has a lower sensitivity and specificity, somewhere in the neighborhood of 80 to 85%. And so for true nodal staging, we always combine the data that we get from the CT chest, the PET CT, and then we also always want to do some mediastinal sampling to determine truly if nodes are involved or not. In terms of imaging, though, other than a CT scan and a PET scan, we always want to get a brain MRI with contrast to rule out brain metastases, because non-small cell lung cancer and small cell lung cancer both have very high propensity for brain metastases. With non-small cell lung cancer, brain MRI is really mandatory for anything greater than 4 centimeters, so stage 2 disease, and it's optional for stage 1B, so greater than 3 centimeters, but it is mandatory for all small cell lung cancers. So very, very early stage non-small cell lung cancers, you may not have to get a brain MRI, but it's good practice. So in terms of imaging, just remember CT chest, PET CT, and then brain MRI for these patients. And then finally, that brings us to our pathology and our mediastinal staging. So ideally, we always want to get a preoperative biopsy. And then if we're going to be going for surgery for an early stage lung cancer, the mediastinal staging is done at the time of surgery. And if we are going to be treating these patients with radiation, then we do try to get good mediastinal sampling. And we'll talk about the methods for that. But we try to get good mediastinal sampling before we treat them with radiation. The reason for this is because mediastinal sampling helps us to confirm their stage, and it helps us to make sure that no lymph nodes are involved and we're truly dealing with early stage patients. So the NCCN guidelines say that for stage 1A lung cancers, so tumors that are less than or equal to 1 centimeter in size, if we are dealing with a high pretest probability of malignancy, so for example, it looks like it has spiculated margins, we have evidence that it's been growing, maybe the patient has different risk factors, so high pretest probability of malignancy, we may just take them directly to surgery without getting any biopsy up front. If patients did not have a preoperative biopsy, then we try for an intraoperative wedge resection or a needle biopsy before committing them to a lobectomy. So that makes sense, right? If a patient's going to surgery and we don't yet have a tissue diagnosis of lung cancer, then we do a more minimal sampling before we commit them to taking out an entire lobe of their lung. And then in most cases, like I said, we are going to prefer a preoperative biopsy of some sort to help us with our treatment decisions. So if the tumor is located peripherally, this can be a CT-guided biopsy. And if it's located more centrally, then we can go endoscopically, so doing a bronchoscopy and then doing an FNA of that more central lesion if it is accessible. As you can imagine, getting a preoperative biopsy is very helpful for us because it can help us to see, number one, is this even cancer? For certain patients that have larger tumors, they may benefit from preoperative systemic therapy, and so it can help guide our treatment decisions in that space. Sometimes, if we're just going to be treating these patients with SBRT, for example, so with radiation, it helps us to establish that diagnosis of lung cancer before we proceed with SBRT. We spoke earlier a little bit about pathology, but the main pathologies to know for lung cancer are listed here on this slide. And again, the most important differentiator is non-small cell versus small cell lung cancer. And remember, we said small cell lung cancer is a high-grade neuroendocrine tumor that's almost always associated with smoking. These tumors do tend to be located centrally, and sometimes it looks like they just have a very large mediastinal lymph node, and we often don't even see kind of a peripheral primary tumor with these cancers. With non-small cell lung cancer, it accounts for around 85% of lung cancers, and squamous cell account for a smaller portion. These do always tend to be associated with smoking, and they also tend to be located centrally, similar to small cell lung cancers. And then the vast majority of non-small cell lung cancers are adenocarcinomas, and up to 20% of these may actually not be associated with smoking. Adenocarcinomas tend to be located more peripherally in the lung. And then there are some less common histologies within non-small cell lung carcinoma as well, including large cell, as well as carcinoid tumors, which are actually a low-grade endocrine tumor. And so, the reason that we differentiate non-small cell versus small cell is because, these are treated as completely different disease sites. Small cell lung cancer is treated much more as kind of a systemic disease. And so it's really important to make this distinction before we commit patients to a treatment path. We mentioned earlier how pathologic samples are obtained. So for the lung tumor itself, we will either do a CT-guided biopsy, or if it's a centrally located tumor, then it's easier to access via endoscopy. So then we'll do kind of a bronchoscopy and access it that way with fine needle aspiration. In terms of mediastinal staging, we also have a few different options. So as we mentioned earlier, for nodal staging, PET can have high false negative rates, up to around 15%, based on this study by Al-Saraf al. So in this study, up to 15% of patients that had negative N2 or N3 station nodes on the PET scan turned out to have positive N2 or N3 nodes on surgical staging. And so that's why it's really important for us to get good mediastinal staging, especially if patients are not going for surgery and we're committing them to radiation. So what are some ways that we can get that mediastinal staging? So one method is to do an endobronchial ultrasound, and this is usually done by a pulmonologist or an interventional pulmonologist, but a bronchoscope is used to kind of take a look at the airways and visually assess for any abnormal looking lymph nodes using ultrasound. And anything that looks abnormal, the pulmonologist can perform a fine needle aspiration and sample some levels. This method is beneficial because oftentimes during the procedure, we can actually get some frozen pathology for very quick idea of whether or not things are involved. And it allows the pulmonologist to sample levels 2, 4, and 7, which are sort of located in the mediastinum. Level 7 is a subcarinal node, and then level 10 is actually a hilar node, so it can sample the hilar nodes as well. So we can sort of sample some more areas with this endobronchial approach. And this is usually a preferred approach. Mediastinoscopy is another method. The endobronchial ultrasound can be performed under what we call conscious sedation, so light sedation, similar to what patients would get for a colonoscopy. The mediastinoscopy actually requires general anesthesia, and a small incision is made over the mediastinum, and a scope is actually introduced through the skin into the mediastinum in order to sample lymph nodes. So this is a little bit more invasive, and it only samples kind of central nodes, so levels 2, 4, and 7, doesn't access the hilar nodes. This method also allows for us to obtain some frozen sections at the time of the procedure, and oftentimes mediastinoscopy is reserved for possible restaging and not used up front. There is a trial called the ASTER trial to be familiar with, and it's basically a randomized trial, and its results aren't mind-blowing. Basically, they found that an endobronchial ultrasound is more sensitive than a mediastinoscopy alone. The most sensitive results we can get are if we first perform an endobronchial ultrasound and then perform a mediastinoscopy if nothing is found on the endobronchial ultrasound. But I would say the preferred approach for mediastinal staging is for us to get that bronchoscopy with what we call EBUS, or that endobronchial ultrasound. It's extremely important for us to get a good tissue specimen for the cancer, because we use that specimen to perform kind of molecular and biomarker testing that can help us to then personalize our treatments for cancer patients depending on what is expressed. One very important test that we perform is PD-L1 testing. So PD-L1 stands for programmed death ligand 1, and this is a marker that may be expressed by cancer cells which prevents T cells from killing them. So normally our T cells express PD-1, and when they bind to PD-L1, that sends kind of repressive signals to the T cell and causes the T cells to kind of tone down the immune response. And so cancer cells have very brilliantly evolved this mechanism of binding to the PD-1 on our T cells and shutting down our body's immune response, thus preventing us from fighting the cancer. We can measure how much PD-L1 is expressed by the cancer cells by measuring what is known as the tumor proportion score, or the TPS. So that tells us what percentage of viable tumor cells show either partial or complete membrane staining for PD-L1. And anything greater than or equal to 1%, so a TPS of 1% or more, is considered positive. So if the TPS is 1% or more, the cancer cell is said to be PD-L1 positive. If we are dealing with a PD-L1 positive tumor, then we can employ immune checkpoint inhibitors that actually target either PD-1 or PD-L1. So these are the immunotherapy drugs that we're probably all very familiar with. So things like durvalumab, atezolizumab, pembrolizumab. These target either PD-1 or PD-L1, and they kind of shut down that negative feedback that shuts down our T cells and our immune response, and it helps our body to keep that immune system active and help fight off the cancer. And so these immune checkpoint inhibitors are utilized very commonly in both non-small cell lung cancer, and now we actually have data for using them for small cell lung cancer as well. And we employ these immunotherapies often in the neoadjuvant setting, in the adjuvant setting. And for patients that have metastatic disease, if they have a TPS that's greater than or equal to 50%, then they may even qualify for just monotherapy with immune checkpoint inhibitors. So PD-L1 testing is very, very important. On that path report, you might see something known as the TPS score. And keep in mind that anything greater than or equal to 1% is considered positive, but TPS of 1% is very different than TPS of 50%, which is very different than TPS of 90%. So really depending on what that TPS is, if the patients are PD-L1 positive, and if so, how much, we can kind of decide, do we rely solely on immune checkpoint inhibitor monotherapy, or do we do it with a combination of chemotherapy, or do we not utilize it at all? We are now aware that there are several other targetable mutations in non-small cell lung cancer. And in the last several years, we've found several different genes and developed several different drugs that can specifically target these various genes. And so it's very important for us to obtain a good tissue sample and also perform next generation sequencing on our tumors to identify potentially targetable mutation. So whenever possible, we want to perform next generation sequencing. And if there is a presence of a targetable mutation, then right now we have evidence for certain genes that targeted therapy should take precedence over immune checkpoint inhibitor. So the two genes that we have very robust evidence for as of now are the EGFR and the ALK genes, and then many of these other genes are currently under investigation. So EGFR is a gene that can be mutated, and there are different types of mutations that can happen. So the most common mutations are an exon 19 deletion or exon 21 L858R mutation. And both of these types of mutations, so exon 19 and exon 21 for EGFR, are targetable with a drug known as osimertinib. So osimertinib is a third-generation tyrosine kinase inhibitor that irreversibly inhibits the activity of EGFR. There are first and second-generation TKIs as well. So erlotinib and gefitinib are first-generation TKIs. Afatinib is an example of a second-generation TKI. Unfortunately, with these first and second-generation TKIs, the EGFR can actually acquire a type of mutation known as T790M mutation, and that can lead to resistance to these first and second generation drugs. And so we have now developed a third generation drug known as osimertinib, which is very effective. There is one type of mutation of EGFR, so an exon 20 insertion. And if that exon 20 insertion is present, then osimertinib does not work for EGFR, and we actually have to utilize a different drug. So just remember osimertinib for patients that have EGFR mutation, and remember that they have to have a certain type of mutation, so exon 19 or exon 21. Exon 20 does not work, unfortunately. The other mutation that we talked about is ALK. So patients with ALK rearrangements can be treated with alectinib, and that's easy to remember, ALK and alectinib. And we can utilize alectinib for both early stage or metastatic patients. There's a newer drug, lorlatinib, which has been studied for metastatic patients, but unfortunately it has a slightly higher risk of CNS toxicity. So these are some common drugs that you will be seeing that are used for patients with these specific targetable mutations. And then there's other mutations that we can test for as well, such as ROS1, BRAF, MET, RET, KRAS. And so this is a kind of an area of ongoing study within non-small cell lung cancer. And whenever possible, if patients do have a targetable mutation, our therapy against that targetable mutation should take precedence over other things such as immune checkpoint inhibition. Finally, I will briefly mention testing for circulating tumor DNA or ctDNA for advanced or metastatic non-small cell lung cancer. So we can perform what is known as a liquid biopsy, where we can actually obtain a blood sample and perform a mutational analysis and actually test for circulating tumor DNA. The advantage of this method is that it allows us to more quickly get some results and get a sense of if patients have certain targetable mutations. A common example of what is used for liquid biopsy is something called Guardant 360 testing that actually tests for 73 different genes. And if something targetable is identified via Guardant testing, then we can maybe even more quickly initiate patients on therapy, especially if they have metastatic disease. ctDNA testing, importantly, does not replace a histological tissue diagnosis. So we always need to obtain pathology, but this liquid biopsy can provide some information and help kind of guide our systemic therapies a little bit quickly sometimes, a little bit more quickly than if we waited for the pathology results. But it should definitely not replace tissue histology at this time. So now that we've reviewed the presentation and workup of lung cancers very generally, I'd like to talk about the staging and management of the different types of lung cancer. We'll start with a discussion on non-small cell and then move on to small cell. Before we get into the staging for non-small cell lung cancer, just very briefly to review the anatomy, we remember that we have our right lung and our left lung. The right lung is divided into upper, middle, and lower lobes. The left lung is divided into the upper lobe and the lower lobe, and in place of the middle lobe, we have what is called the lingula. The middle lobe is lacking in the left lung because the heart kind of takes up that space. The trachea divides into the main stem airways, and then those branch out into our lobar branches, which then further branch out into our segmental branches. The heart kind of sits in between the two lungs. Running posteriorly to our trachea and our bronchi, we have our esophagus, which sits right in front of our vertebral bodies. And then obviously superiorly, the aorta comes off of the heart. And these are just vessels that are important to kind of remind ourselves of. So we have 3 branches off the aortic arch. So the first is the brachiocephalic artery, which gives rise to the right coronary artery and the right subclavian artery. The left carotid artery and the left subclavian artery directly come off the arch of the aorta. When we're looking at CT scans and evaluating lung cancers, these are some of the common anatomy questions that may come up. The other very important anatomic consideration is our mediastinal and our hilar nodes. So the nodal stations in the lung are numbered 1 through 14. And so the first station where cancer can spread, if it spreads to the nodes, is the nodes that are closest to the periphery of the lung. So these are our hilar nodes. And hilar nodes are labeled with double-digit numbers. So stations 10 through 14 are what are known as our hilar nodes. And if those are involved ipsilaterally, that is known as N1 disease. So if you have ipsilateral hilar nodal involvement, that makes you N1, and that automatically makes you stage 2B disease. So having just the hilar nodes is still stage 2. It's not stage 3 at this point. Our mediastinal nodes are labeled levels 2 through 9. One important level to know is the subcarinal nodes, which are level 7. But anything single digit, so 2 through 9, are what are known as our mediastinal nodes. And again, if the mediastinal nodes are involved ipsilaterally, then that makes you N2 disease. And at this point, it is considered stage 3 disease, specifically stage 3A. So single digit nodes 2 through 9 are mediastinal nodes, and if they are involved ipsilaterally, that is N2 disease, which makes you stage 3A. If you have contralateral mediastinal or hilar nodes or supraclavicular nodes involved, so that is now level 1 nodes, that upgrades to N3 disease, which is stage 3B disease. So there is a distinction between 3A and 3B. 3A is N2 disease involvement, and 3B is N3 nodal involvement. One thing I will mention, so levels 5 and 6 are our subaortic and para-aortic nodes respectively. And by definition, levels 5 and 6 are left-sided nodes. So if a patient has a right-sided primary and then levels 5 or 6 involved, by definition, that makes them N3, stage 3B disease, just because 5 and 6 are left-sided nodes. Levels 2, 3, and 4, we have L and R, so they have laterality, but 5 and 6 are really, left-sided nodes, and then 7, as we said, are our subcarinal nodes. So just to recap that mediastinal and hilar anatomy, hilar nodes are the double-digit nodes 10 to 14. If they are involved ipsilaterally, it's N1 disease. The mediastinal nodes are single digits 2 through 9, and if they are involved ipsilaterally, it's N2 disease. And then if we have contralateral mediastinal or hilar nodes, or those level 1 supraclavicular nodes, that makes us N3 disease. I think that anatomy background, especially for those nodal stations, is really important to understand because it really informs our staging for non-small cell lung cancer. And the reason we really focused on that in the non-small cell lung cancer section is because, as we will see, the TNM staging and the group staging is really more relevant for non-small cell lung cancer than it is for small cell lung cancer. It's the same exact system of group staging and TNM staging, but with small cell lung cancer, we typically use a different system and we don't as much rely on TNM. But for non-small cell, this is very, very important to know. So we did just talk about the end stages for non-small cell lung cancer. The T stage is really based on size. So T1 is 1 to 3 centimeters, T2 is 3 to 5 centimeters, and then 3 is 5 to 7 centimeters, and anything greater than 7 centimeters is 4. So just remember the numbers 3, 5, and 7, and those will kind of help us to establish those cut points between T1, T2, T3, T4. T2 can also be made T2, specifically T2A, if there is invasion of the main bronchus, the visceral pleura, or if there's an obstructed airway. So just remember, like visceral pleural invasion or bronchial involvement causing even obstruction sometimes, that makes you T2. If there's parietal pleural invasion, chest wall invasion, invasion of the parietal pericardium, or a separate nodule in the same lobe, that can also make you T3. And then finally, T4 stage is if there's a separate nodule in another ipsilateral lobe. So for example, if you have a right upper and a right middle lobe lesion, that would be T4. Or if disease is either invading into the mediastinum or if it's invading into the chest wall. And then M1 disease is if there is a metastasis. So M1A disease can be a contralateral lung tumor, so that is considered a metastasis, or if there's any pleural involvement, whether that's a pleural nodule or a pleural effusion. M1B disease is if there is a single extrathoracic met, and then M1C disease if there's multiple extrathoracic mets. So that's sort of the TNM staging. In terms of group staging, I think what's really important to realize is that if you have ipsilateral hilar nodes, so N1 involvement, that's still stage 2, it's just stage 2B. As soon as you have mediastinal nodes involved, so as soon as it's N2, that makes you 3A, or if you have T3N1, that makes you 3A as well, T3 to T4N1. And then if you have T4 and 0, that's another reason to be stage 3A. And then if there are N3 nodes involved, and at that point you're considered stage 3B. So I just think that's a really important distinction to make is 2B versus 3A versus 3B. So this brings us to a summary of our management for non-small cell lung cancer. And on this slide, we're talking about stage 1 to 3 non-small cell, so disease that is potentially curable. And keep in mind that as the stage goes up and as the tumor becomes more advanced, the likelihood of cure drops. But despite that, all of these patients we would be treating with the goal of curing them. So very broadly, non-small cell lung cancer that's potentially curable is divided into early stage versus locally advanced. Early stage disease we typically think of as stage 1 to 2 disease. And there are really 2 routes that a patient can go. If a patient is a fit candidate for surgery, if they're medically operable, and if that is the path that they wish to pursue, then they are candidates for surgery, and they can either be treated with a lobectomy, which was historically the standard of care for decades, but we now know that if tumors are 2 centimeters or less in size, they don't necessarily need to take out the full lobe. They can get away with a sublobar resection, so either a wedge resection or a segmentectomy. So that's one option, that they can just pursue surgery. And historically, we would often think about giving adjuvant systemic therapy for patients with particular risk factors, so stage 2 or above. In the modern era, if we're going the route of systemic therapy, we'll often take a neoadjuvant approach and do neoadjuvant chemoimmunotherapy. So that's the surgery arm. If they are amenable medically and if they want to go that route, then they can be treated with surgery. For patients that are medically inoperable or they're very high risk for surgery or they refuse surgery, then we can treat them with definitive radiotherapy. And what we will typically use for early stage disease, if we're able to technically, is SBRT. So SBRT is considered a high dose per fraction. This is stereotactic body radiotherapy, and we're typically treating them in anywhere from 3 to 5 fractions. And there's some technical considerations. So the tumor size should be less than or equal to 5 centimeters, and they should not have any nodal involvement, and they should not have central or ultracentral tumors if we're going to be treating with 3 to 5 fractions. If they have central tumors or tumors that are abutting critical mediastinal structures, such as the bronchi or the pulmonary artery or something like that, that's okay. We can still treat them ablatively with radiation. We just have to use more fractions, so somewhere like 8 to 15 fractions. So those are really the two routes for early stage disease, is the surgery route or the radiation route. And most often, if they're getting radiation, they're getting SBRT. For locally advanced disease, so disease that is considered node positive, certain patients may still be candidates for surgery. So for example, if they have stage 2B disease, if they have N1 disease, or if they have limited stage 3, so single station N2, stage 3A disease, they may be candidates for surgery. And again, if they're getting surgery, they would probably be getting some sort of chemoimmunotherapy either before or after surgery. The criteria for what is considered surgically resectable versus unresectable are really controversial and a little bit murky. And you will find that it really depends on the institutional practice as well as the individual comfort level of the surgeon. But very broadly, and this is a huge generalization, may not be applicable to all centers, but very broadly, we typically think of N3 disease, bulky N2 disease, so things measuring greater than 3 centimeter, so bulky nodes, or multiple N2 nodes. We consider those as unresectable factors. And it's a mix of kind of technical considerations, or the likelihood of getting an R0, meaning margin negative resection, as well as prognostic considerations, meaning these patients are more aggressive and they're probably going to have a poorer prognosis. And so we typically think of them as not good candidates for surgery, and we treat them with definitive chemoradiation. So that's 60 gray and 30 fractions with weekly concurrent chemotherapy, usually double agent, something like carboplatin and paclitaxel. And then after chemotherapy on the back end, we typically give them maintenance immunotherapy with durvalumab. Some patients can get maintenance osimertinib if they have the appropriate EGFR mutation. So definitive chemoradiation is really the standard of care for stage 3 disease that's not going to be treated with surgery. And then finally, we have superior sulcus tumors, which are what we think of as our Pancoast tumors. And we'll talk about the study for this in our next lecture. But a different paradigm has kind of emerged for superior sulcus tumors. And these are typically treated with preoperative chemoradiation, usually to a lower dose, somewhere around 50 gray. And then they are taken for surgery. So that's very broadly, in a nutshell, some of the considerations for local therapy for non-small cell lung cancer. So we have early stage, either surgery or radiation. If they go the surgery route, certain patients, especially stage 2 or higher, may get some sort of systemic therapy either before or after surgery. And then our locally advanced patients can either go for surgery with systemic therapy either before or after, or they can get the definitive chemoradiation followed by adjuvant maintenance therapy. And those are kind of the big options for treating non-small cell lung cancer. So just to go into some more details now about all these options we talked about. We mentioned surgery is an option. So whenever possible, we prefer lobectomy. And lobectomy is really the historical standard. It's preferred over pneumonectomy, which is where we take out the entire lung. As you can imagine, patients do much better when they just have part of their lung removed, so a lobectomy rather than a pneumonectomy. There was an old study that showed that even for early stage lung cancer, we really should be performing lobectomies and not wedge resections or segmentectomies. But our surgical methods have improved, and there's actually a newer alliance study that supports sublobar resection, so either a segmentectomy, which is kind of a more anatomical resection, or a wedge resection, which is kind of just taking out the tumor with a margin. These approaches were shown in an alliance study to be non-inferior to lobectomy, specifically for T1A to B tumors, so tumors that measure 2 centimeters or less. what we need to do is aim for margins of at least 2 centimeters or at least the size of the nodule that we removed if we are pursuing a sublobar resection. But this is an option for patients with 2 centimeter or smaller tumors. And whenever possible, we try for minimally invasive approaches. So kind of a video-assisted or robotic-assisted approaches, minimally invasive whenever possible. During surgery, we need to have adequate nodal assessment. So the lymph node levels should be adequately mapped and resected. And there are guidelines for what is considered an adequate nodal assessment. And at minimum, 1 station from the N1 region, so those hilar nodes, and 1 N2 station, so that's those levels 2 through 9 mediastinal nodes, should be sampled. Or you can do a complete lymph node dissection, but at minimum, we need 1 N1 and 3 N2 stations to be sampled. And if N2 disease is found to be present, then we need a formal ipsilateral mediastinal lymph node dissection. Systemic therapy is, I think, where it can get a little bit complicated, especially when we're combining systemic therapies and surgery. So historically, the standard was surgery, and then if certain risk factors were found at the time of surgery, typically that meant if these patients were stage 2 or above, so tumors measuring 4 centimeters or higher, or if they had node positive disease, then some sort of adjuvant therapy would be given. And historically, that adjuvant therapy was a platinum-based doublet chemotherapy. We then started to add immune checkpoint inhibition, and we then realized that if patients have EGFR or ALK mutations, instead of immune checkpoint inhibition, we can do targeted therapy. So osimertinib for those EGFR mutations or alectinib for those ALK rearrangements. So that was sort of the adjuvant paradigm. In the modern era, we have really moved towards neoadjuvant chemoimmunotherapy. So if patients, and that's because also in part our imaging has improved and our staging has improved, so we have better ways of telling if these patients are going to need immunotherapy or systemic therapy on the back end. And if they have tumors that measure 4 centimeters or greater, or if they are node positive, and they don't have EGFR or ALK mutations, and that's something that's known up front, we should then evaluate these patients for preoperative therapy. And so they can be treated with neoadjuvant chemoimmunotherapy for 3 cycles and then be taken for surgery. And there's also emerging data for perioperative systemic therapy as well with some ongoing trials. So I would say in the modern era with better staging, if we think that these patients would benefit from systemic therapy, we're trying to give that up front. And the advantage of giving it up front is that when they have upfront systemic therapy, these patients are more likely to undergo an R0 resection, and they're just more likely to have better outcomes that way. I would say, for me personally, what makes studying lung cancer the most complicated is having all these options that patients can go, and especially when you start to think about what surgeries they can get and what systemic therapies and when those systemic therapies should be offered relative to the surgery. I really think that is where things start to get confusing. What's very simple, though, I think, is the radiation paradigms. And once the decision is made to treat the patient with radiotherapy, I do think that it's fairly simple what our kind of boxes of treatment are when it comes to radiation. So if they have early stage disease and the disease is amenable to SBRT, then very easily we can treat these patients with SBRT, and there are different fractionation regimens. So anywhere from 1 fraction up to 5 fraction, and some of those dose fractionations are listed there. If they have early stage disease and they have a disease that's technically not possible to be treated with SBRT, so for example, if they have an ultracentral tumor that's not safe to be treated in just 5 fractions, we can still treat them with an ablative dose of radiation. We do it in more fractions, so 8 to 15 fractions. But early stage disease, we can just treat them with radiation. For locally advanced disease, if they're not getting surgery, then we treat them with chemoradiotherapy. So 60 gray in 30 fractions given daily with concurrent chemotherapy, something like carboplatin and paclitaxel, and then we'll follow that up with some type of maintenance therapy. Most commonly, it's adjuvant durvalumab for a year, But if they have the appropriate EGFR mutation, we can treat them with adjuvant osimertinib. So that's locally advanced disease. For metastatic disease, we have various palliative regimens that we can use for their primary tumor if it's causing them symptoms, and then the paradigm is SBRT for any oligometastases, and that has been shown to improve progression-free survival, and in some studies it seems there may even be an overall survival benefit. And then finally, superior sulcus tumors, we talked about how there's sort of a different paradigm for those. We treat them with preoperative chemoradiation to a lower dose, typically around 50 gray, with concurrent chemotherapy. Then they go for surgery, and sometimes they get additional chemotherapy after surgery. The one kind of bucket that I didn't really mention is post-operative radiotherapy. And the use of post-operative radiotherapy has really declined based on some studies that suggested it was negative for patients with high risk factors like N2 or N3 disease. Really, the only indications for post-operative disease in the modern era are if patients have either R1 resection, meaning they have a positive margin, or if they have an R2 resection, meaning they have gross residual. If we do give post-operative radiation, we still have to use that definitive dose of 60 gray. But that is the one area that I didn't have on this slide. And then finally, the last area I want to mention for non-small cell lung cancer is systemic therapy for metastatic non-small cell lung cancer. Because the more that the better our systemic therapies are becoming, the longer these patients live, and the more we start to see them in our clinics with either brain metastases or oligometastatic disease that we're asked to treat. And so it's good to be familiar with what systemic therapy these patients are on. So the general rule that we've sort of already mentioned is that whenever possible, targeted therapy should take precedence over immune checkpoint inhibitors, which should take precedence over chemotherapy. So we always want to obtain histology and the molecular results. And if these patients have a targetable mutation, then we treat them with whatever targeted therapy we can. If they don't have targeted therapies, we treat them based on PD-L1 status. If the PD-L1 is greater than or equal to 50%, as we mentioned, they are amenable for pembrolizumab monotherapy. If the PD-L1 is positive but not quite that high, we can treat them with chemoimmunotherapy, so a doublet chemotherapy and pembrolizumab. And if the PD-L1 is actually negative, I think this is a little bit controversial. So some medical oncologists will still give them the pembrolizumab, and some of them won't, with the argument that the PD-L1 is negative. But in studies that have shown a benefit for PD-L1, when the cohort was taken all together, there was a benefit to the pembrolizumab. It was really on these subset analyses that PD-L1 negative seems to have not had a benefit. And so I think that's an area of controversy a little bit. But just keep in mind that these patients may be on various systemic therapies. I didn't say this, but always, whenever possible, if we can enroll them on a clinical trial, that should be our first intervention. And then otherwise, there are different standards kind of as listed here. So that was a lot of information on non-small cell lung cancer. And I think it's complicated, and it's becoming more complicated as we get more and more studies, more and more molecular markers to chase after, and it's definitely an evolving space. The disease site evolved a lot between the time that I was a PGY2 and a PGY5, and I'm sure it's going to continue evolving, and it's hard to keep up with all the data in this space, but it's really important for us to do that so that we can take the best care of our patients. But for now, that is hopefully a general understanding of non-small cell. And very briefly here, I would like to just discuss the staging and paradigm for small cell lung cancer. So as I mentioned earlier, the TNM staging and the group staging that we discussed for non-small cell lung cancer is the same exact staging that we use for small cell lung cancer. And if you want to stage small cell lung cancer using TNM staging, you can use that system. However, what we actually use for practical purposes when it comes to small cell lung cancer is really just dividing small cell lung cancer into limited stage versus extensive stage. And that's a much more useful and clinically applicable way of staging these patients. And it's very cool to me because limited stage small cell lung cancer, the definition of this is really defined by radiation oncologists. And limited stage is defined as any TN or an M0 that can be safely treated with definitive radiation doses. So if we feel that we can safely encompass everything within our radiation field, it's considered limited stage disease. So typically, this includes anything that's stage 1 to 3 by that AJCC version 8 group staging. It typically excludes things that have multiple lung nodules that are too extensive or too large to be encompassed in a tolerable radiation plan. So anything we think we can safely include in one field, that's limited stage. And then anything that has metastases or things that are too large or extensive, we call that extensive stage. So for small cell, it's just a limited stage or extensive stage, and you'll often see it as abbreviated as LS-SCLC or ES-SCLC, indicating limited versus extensive stage respectively. In terms of treatment for small cell lung cancer, it's really considered a systemic disease because it has such a high propensity for metastasis. And so systemic therapy is really, really important for small cell lung cancer. So limited stage disease is typically treated with either chemoradiation or it's treated with, in rare cases, it can sometimes be treated with upfront surgery. So if it's just T1 to T2, N0, M0, but it's unfortunately, it's uncommon that we find small cell lung cancer at this early of a stage. If it's treated with surgery, then these patients will undergo surgery followed by adjuvant systemic therapy with something like cisplatin etoposide, and then they'll get maintenance durvalumab for 4 weeks. If they're treated with chemoradiation, which is more often what happens, the dose that we use is actually 45 gray in 30 fractions delivered twice daily over a period of 3 weeks. Or if we're doing once daily, we can do 66 gray in 33 fractions. And this chemoradiation is given concurrently with cisplatin and etoposide every 3 weeks. And we typically try to start the radiotherapy either with cycle 1 or cycle 2. It can be difficult to start our radiation with cycle 1, and it's often quicker just to initiate these patients on systemic therapy. And arguably, that's what's more important for them anyway. And so sometimes we will start our radiation with cycle 2. When we give chemoradiation, like I said, it's something like cisplatin and etoposide given every 3 weeks for 4 cycles. And then these patients will get adjuvant durvalumab for 4 weeks. Giving adjuvant durvalumab for limited stage small cell lung cancer is a new treatment paradigm that's based on a very recently published study called Adriatic that was just presented within the last year, and it showed very important, very significant improvement in progression-free survival and overall survival, kind of almost doubled survival for these patients. And so that's kind of a novel paradigm change within the last year. For extensive stage disease, we can give carboplatin and etoposide every 3 weeks for 4 to 6 cycles, followed by maintenance durvalumab. With small cell lung cancer, we actually have data for providing consolidative thoracic radiation, so 30 gray and 10 fractions, your typical palliative dose. But there's data for consolidative thoracic radiation if patients have a good response to upfront chemotherapy, even with extensive stage disease. And with small cell lung cancer, there's also data for prophylactic cranial irradiation. And I didn't mention this for limited stage, but there's data for prophylactic cranial irradiation in both limited stage as well as extensive stage disease. As I said earlier, small cell lung cancer has a high propensity of metastasis to the brain. So let's start by talking about limited stage disease. So we have data that if patients respond well to their upfront chemoradiotherapy for limited stage disease, then there's actually an overall survival benefit to prophylactic cranial irradiation. The caveat is that this data that we have emerged in a pre-MRI era. So without MRI, we were probably missing so many brain metastases, and so many patients that maybe already had brain metastases were being treated with prophylactic cranial irradiation. But nevertheless, based on that data, and because there's still no randomized data that offers better evidence, PCI is the standard of care, and it has been shown to reduce their risk of brain mets from 60% down to 30%. There is an ongoing trial called Maverick. It's a SWOG study, but it's called the Maverick trial. And it's randomizing patients with both limited stage and extensive stage small cell lung cancer to either PCI with MRI surveillance or MRI surveillance alone and stereotactic radiation if they were to get any brain metastases. So that will be very interesting to follow up. In terms of extensive stage lung cancer, there is level 1 evidence based on a Japanese randomized trial that supports MRI surveillance alone without a detriment in overall survival. And so for extensive stage patients, many have moved to just offering MRI surveillance with SRS if they're found to have brain metastases. But PCI is still also an established standard of care for extensive stage patients. And so the big takeaway here, I think, is that prophylactic cranial radiation is offered for patients with small cell lung cancer because they have such a high propensity for brain metastases. For limited stage, we do not have any randomized evidence supporting MRI surveillance with SRS if they develop brain mets. And so the standard is still PCI, that's 25 gray and 10 fractions. We use an IMRT approach and perform hippocampal avoidance so that we're sparing their memory centers. But it's 25 gray and 10 fractions PCI if they have good performance status and good response to upfront chemoradiation for limited stage disease. For extensive stage disease, there is level 1 evidence supporting MRI surveillance alone, and we're waiting for that Maverick trial, which looks at both limited and extensive stage. I think both options are viable. So PCI or MRI surveillance with SRS if they do have brain metastases. So this brings us to an end of a very long overview of non-small cell lung cancer. I've tried to summarize some key points here on this slide, but obviously there's a lot and it doesn't really go into all of the details. The one thing I did want to make a point to mention, we talked about PCI or prophylactic cranial radiation extensively for small cell lung cancer. But non-small cell lung cancer also does have a fairly high rate of brain metastasis. And there are a couple of studies that have looked at PCI for non-small cell lung cancer as well. And this was offered to patients at one point. But based on the randomized data that we have, there's an RTOG trial, and then I think there's a few other ones as well. But these trials showed that with PCI for non-small cell lung cancer, patients did have decreased rates of brain metastasis. So from somewhere around 20% down to somewhere around 10% at 1 year rate of developing new brain metastases. But there was no difference in overall survival or disease-free survival or quality of life. And, giving any type of whole brain radiation comes at a cost of neurocognitive memory decline. And so PCI is not routinely offered to patients with non-small cell lung cancer. With small cell lung cancer, and we'll go into this data down the road, but with small cell lung cancer, we have seen an overall survival benefit. And so that's really why it is still standard of care. But we didn't see that with non-small cell lung cancer. So I just wanted to take a point to mention that. And other points, remember, it's very important to screen patients whenever we can. They should have thorough workup. And we talked extensively, I think, about the differences in the treatment paradigms for non-small cell versus small cell lung cancer. So that is all I have. Thank you so much for your time and attention. I look forward to future talks where we can start to unpack some of the evidence for all these paradigms that we talked about.